This is Daniel Tobes presenting medically challenging case presentation, dissecting complicated labor, a parturient after a spontaneous coronary artery dissection, along with Dr. Jacob Kramer and Dr. Bruce Skolnick. This presentation begins with a 27-year-old parturient at 11 weeks who experienced a spontaneous coronary artery dissection requiring placement of multiple drug-eluting stents in our catheterization lab. She was later found to have a deep vein thrombosis in her neck that required therapeutic anticoagulation for the remainder of her pregnancy. She ultimately presented prior to her scheduled cesarean section date in our labor and delivery suite in spontaneous labor. She ultimately required a general anesthetic as opposed to the planned neuraxial anesthetic for her cesarean section. This presentation will focus on the appropriate timing of planned cesarean deliveries, especially in pregnant patients with cardiac comorbidities, the management of anticoagulation in pregnancy and surrounding neuraxial anesthesia, the management of patients with unstable cardiopulmonary status. So the first thing that you want to address when you have a pregnant patient who has cardiovascular disease is you want to schedule a multidisciplinary team meeting. This should include at least the obstetrician, cardiologist, anesthesiologist, and a neonatologist, amongst other specialties if felt necessary. There are really two options for patients with tenuous cardiopulmonary status. One is to allow them to undergo spontaneous labor, and the other that we usually utilize in patients who are on chronic anticoagulation is to schedule an induction so that we can adequately manage said anticoagulation. In terms of anticoagulants used during pregnancy, there are really a few preferred medications, and there are a few that are really off limits. Medications that you absolutely should not give during pregnancy. Warfarin is considered category X, and then our novel oral direct thrombin inhibitor, dabigatran, and our other novel oral direct factor 10A inhibitors, rivaroxaban, abixaban, and edoxaban, really have not been adequately studied in pregnancy, so the medical literature suggests that you should avoid them. Listed below are a few other non-anticoagulation medications that we avoid during pregnancy, specifically ACE inhibitors and ARBs, statins and amiodarone. In terms of anticoagulants that we do use during pregnancy, heparin is the mainstay of our treatment, both unfractionated heparin and low molecular weight heparin. The advantages to specifically unfractionated heparin is the ease of titration and how quickly it washes out of the system, and the fact that it can be reversed should it need to be with protamine. Low molecular weight heparin is similar, although it takes a little bit longer. And there is still a risk of heparin-induced thrombocytopenia in low molecular weight heparin. Fondaparinux and argatroban are much less commonly used in pregnancy, typically only in patients who have a history of HIT. In terms of timing for induction and anticoagulation for patients who are on chronic anticoagulation, typically if the patient has a medical history that portends a threatened preterm birth, namely if they have been inpatient on the antepartum unit frequently or for a long time, we will typically switch these patients to unfractionated heparin from whatever longer-lasting anticoagulation they've been on before the 36 to 37 week gestation, just so that we don't get caught by surprise if they happen to go into spontaneous labor earlier. And then patients who don't have any risk factors for early labor, we typically switch to unfractionated heparin at 36 to 37 weeks. And then if they come in spontaneous labor, it's usually adequate to discontinue the unfractionated heparin at the beginning of their spontaneous labor. And if they're coming in for an induction of labor, then we typically have them stop 24 hours prior. 24 for therapeutic doses and 12 hours for prophylactic doses of anticoagulation. In terms of neuraxial timing on patients and on anticoagulation, for unfractionated heparin, you need 4 to 6 hours before you are safely able to place a neuraxial anesthetic. And we typically want a normal APTT. And then from the time that the neuraxial procedure is performed, you need 1 hour before you give the next dose. Sub-Q unfractionated heparin, we typically, again, need 4 to 6 hours and a normal APTT, and then the 1 hour from the procedure time to the next dose. Low molecular weight heparin is a little different. If you're on therapeutic doses, you need 24 hours, and then you need to wait 4 hours after catheter removal before you redose, and it is not recommended to dose therapeutic low molecular weight heparin with a catheter in place. And then prophylactic dosing, you need 12 hours from last dose. And then you need to wait, again, 4 hours after the catheter is removed for your next dose. If you are on single daily dosing, you can dose prophylactic low molecular weight heparin with a neuraxial catheter in place. However, we do not recommend twice daily dosing. A few individual pearls of wisdom. Primary C-section is still only indicated from a maternal perspective in select cases, specifically Marfan's with dilated ascending aorta, aortic dissection, or acute heart failure. Typically, of the valvular disturbances that pregnant patients experience, mitral stenosis tends to be less well tolerated, whereas aortic stenosis and also hypertrophic cardiomyopathy tend to be more well tolerated. And you want to avoid a single-shot spinal anesthetic in patients with a fixed cardiac output because of the risk of a decrease in cardiac output from cardiac accelerator fibers and also the hypotension that typically ensues. And neuraxial anesthesia is usually preferred to attenuate the cardiac stress accompanied with pushing. So for a patient who's on the edge of considering a neuraxial anesthetic with a tenuous cardiopulmonary status, we would typically advise them to get neuraxial anesthesia prior to spontaneously pushing. Thank you.